Hello. Today we're discussing about induction of labor. It's an important element because you realize that a number of pregnancies would actually require induction, and not all pregnancies that will sometimes it will reach actually term, and sometimes it goes beyond term, and sometimes you actually face with a condition that warrant an induction of labor. And this is the basis of why we are discussing induction of labor in this. By definition, induction of labor is the initiation of uterine contraction with the aim of achieving a vaginal birth before the onset of labor. So there should be no labor process. But there's also another one called augmentation, when there's already actually labor and probably the contraction or the labor process is not what you require, then we actually consider you to be augmenting. If you give up any medications or you do any procedures that will increase the contraction, we call that induction of labor, and it normally occurs after 28 weeks of gestation. So we realize that most women will actually go into labor spontaneously by 42 weeks of gestation, but about 1 in 5 will require an induction. That means that about 20% of them will actually require an induction. So that means 20% of the pregnancy who might go beyond 42 weeks of gestation. And it's such a general rule that it's performed when it is thought to be beneficial to the baby. So there should be risk-benefit analysis that should be done for this process to occur. There are quite a number of conditions that you need to meet for you to consider a woman for induction of labor. And one of them is actually prolonged pregnancy. Prolonged pregnancy defined as pregnancy that has gone beyond 42 weeks of gestation. In case you have preterm rupture of membranes, that is rupture of membranes before term, or pre-labor rupture of membranes, you could actually consider induction of labor. In the event that there is an intrauterine growth restriction or history of precipitate labor, there are some women who actually can go into precipitate labor and progress so fast that within the shortest period they're already pushing. So you don't need them to develop this condition maybe when they are at home. So you plan delivery with them. Sometimes there is also maternal request, which is controversial, that you need to actually discuss thoroughly with the mother so that they know the risk associated with induction vis-a-vis waiting for labor to start spontaneously. And then in the event that the baby is not alive, and then suspected macrosomia. If you suspect macrosomia by 38 weeks, 39 weeks, then you do not want this baby to keep growing and risking the mother something else. Also, you need to consider contraindications. These contraindications can be absolute. That means that in the event that a mother has this condition, you should not be allowed to do induction of labor. They are relative that you can still discuss with the mother and discuss, you look at the risk versus the benefits. And these are relative contraindication. In the absolute contraindication, if there is cephalopelvic disproportion, you cannot do a labor induction if you think the baby's head cannot actually pass through a pelvis. Either the baby's head is big or the pelvis is inadequate. When the pelvis is adequate, or the baby's head is normal but the pelvis is actually contracted. In major placental previa, 2A and above, you cannot do induction of labor. Vasa previa, when the blood vessels are lying in the lower uterine segments. And cord prolapse in transverse lie, of course, this is an absolute contraindication. Active primary genital herpes the genital herpes are more likely going to infect the babies and then cause them encephalitis. So you do not want to expose these babies to genital herpes. And then if a mother has ever had a classical cesarean section, the upper segments, when there is a scar in the upper segments, it's a poor scar. That means that it can easily cause a rupture. The relative contraindications are pretty straightforward. Triplets, when you have a low transverse cesarean section, non-repeated indications. Then you also have a breech breech presentation. This had a definition of terms. There are modifications from the traditional ones that we used to say there's preterm, then there's term, and then post-term. Now the term itself is divided into early term, which is actually spans from 37 weeks to 38 weeks and 6 days. And then full term between 39 weeks and then 40 weeks and 6 days. And then late term is between 41 weeks and 41 weeks and 6 days. So that's late term. So as a tradition, we normally do not want babies to go beyond 41 weeks because the rate of neonatal morbidity and mortality increases after 41 weeks. So you don't want to risk a baby at that time. And also, we should actually allow babies to go at least beyond 37 weeks. The ideal time, if there's a problem for delivery, is actually at 39 weeks. But for induction, the ideal time is actually at 41 weeks. So when you're doing cesarean section, yes, perfect time is 39 weeks. Because by 39 weeks, you realize that maybe 10% of the mothers have undergone, they could have gone to labor. Yeah. And then that means, you have 90% of them you actually do electively. What is failed induction? Very important that you need to know failed induction. Failed induction rates depends on how you actually make the diagnosis, and it's actually 12 to 15% of all cases of induction. And most of them is because of the unripe cervix. When the cervix is not ripe, you're more likely going to have a failed induction. What is failed induction? Is when you try to induce labor and it's unsuccessful. That one we call it failed induction. When do we do induction of labor? It is important, as I said earlier, that you need to wait until the right time. The right time is when there is the neonatal mortality and morbidity, it's at its lowest level, and that is between 39 weeks and 41 weeks. But you give benefit of doubt that these mothers need to wait until they are 41 weeks. If they go beyond 41 weeks, unless conditions actually make it that you need to induce this mother, you need to wait until that time. What happens when a mother delivers at 39 weeks? And this is what this is what I was talking about, the risk of having that. The risk of having problems in all pregnancies at 39 weeks is you can actually have maybe one problem. In low-risk pregnancy, you can actually have one problem, maybe one neonatal event. That can be a neonatal mortality or a neonatal morbidity. Transient tachypnea of the newborn is one of the commonest presentation at that time. And then in all pregnancies, including low and high risk pregnancies, when they're mixed up together, they tend to 4. But you realize that this increases to 7 to 12 by 42 weeks. And we think the best time to deliver is at 41 weeks. Before you induce labor, it's important you need to do a score, and this score will guide you of how more likely you're going to succeed with the induction. And Bishop's score is the one that is used to do that. And it's important that you need to learn how to do a Bishop scoring. And of course, a higher Bishop score of more than 6 or more is more likely to result into labor within a particular time. So you need to aim at a higher BSOP score. If it is a low BSOP score, it means that, especially if the score is less than 5, it suggests that the spontaneous labor will not ensue within the next 2 to 3 weeks. But most of the time, BSOP score is done to make you decide if you need to do cervical ripening or not. And we'll discuss about cervical ripening. And these are the parameters you use when you're doing a BSOP scoring. One of them is actually you need to look at the cervical feature. And then, of course, in the cervical feature, you look at the dilatation, you look at the length of that, you look at the station, then you look at the consistency, and then the position. Of course, this is how you can be able to score it. This is the stations, how you can be able to score. Importantly, you need to identify the ischial spines. You can actually be able to see the ischial spine. If you see this plane where it is labeled 0 here, that's at the level of the ischial spines. The interspinous diameter is actually 0. So when the lowest presenting part touches that point, we call that the presenting point. The presenting part is at station 0. Anything above that point by a centimeter is actually station -1. And anything below that by a centimeter is a station -2, I mean +1. So anything that goes above that, it is negative. Anything that goes below that is actually positive. And you see that they're actually measured in centimeter. And this will give you a very good guide, especially when you're monitoring labor. Let's look at methods of induction of labor. Of course, in Uganda, misoprostol, you see the first drug we're talking about here is not a drug that has been approved for induction of labor. It's actually used for other things, but you can use it as a cervical ripening agent. It's important when you're writing, making a write-up, you're recording in the patient's file, you just say misoprostol is used for cervical ripening. Don't ever say it is used for induction. If you go to court, you'll be in trouble. Of course, we have prostaglandin E, which we have in the market here. It's called Cervidil. We have Foley catheter, which is a mechanical induction method. We can also do amniotomy, can do stripping the membranes. We do a lot of stripping of the membranes, or a membrane sweep. In some people call it membrane sweep. Then laminaria is an hygroscopic materials that will absorb water to itself, and then it swells. So when you put it within the cervical canal, it swells, and then it is able to dilate the cervix. I put this picture so that you're able to see, but of course you're not going to have probably a physical, may not see a physical amniotic hook. It's not there, but these days we just improvise something for rupturing the membrane. How do we do cervical ripening in Uganda? This is actually our clinical guideline, Uganda clinical guideline. Very important. If you look at this, it's very important. It's only indicated when the cervix is not favorable. You can use either misoprostol 200 microgram inserted intravaginally every 6 hours for use 2 doses. If no response, you actually use 50 microgram. But remember that misoprostol that we have in our market is actually in 200 microgram formulation. So that makes it a little bit difficult because we don't have the 25 microgram formulation. We actually modify this. So what we do, we can actually do 20 or 25. But how do we cut tablets into 20 or 25? It's very difficult. Now, this is the trick. You actually dissolve 1 tablet of 200 microgram in 200 mils of water and give either 20 mils or 25 mils 2 hourly until the labor starts, or a maximum should actually be within 24 hours. If you give it within 24 hours and labor has not started, or the cervix is not ripened, actually you first need to stop. You stop at that. But before you give, you need to shake, because this will actually form particles and it settles down. So you shake and then you be able to give it. Just get any normal water, whether Renzori or you get Akosipi or any other form of water, even just water from the borehole. You can use that to mix it. Foley catheter, very perfectly, it's very important here. You normally insert and then you balloon the catheter up to 50 mils. Of course, you've seen in your Foley catheter, you realize that the maximum balloon is 30 mils, but you can actually balloon up to 60 mils. It does not even burst. If it bursts, it actually irritates the membranes, and that will actually another way of induction, which is okay. And then you put pressure on that. You actually put you pull it. We'll be able to demonstrate it one day when we see a patient on the ward. Of course, the only medicine used for induction in Uganda is Oxytocin. What is required before you induce labor? Very importantly, that you need to date this pregnancy very well and accurately. There are wrong dates that you need to actually look at that, and there are many ways you can do the dating. So whatever it is, you need to be sure that the date is actually important. And normally the crown ramp length is the best dating modalities in the scan, and that is done when the pregnancy is actually less than 8 weeks. You see the error boundary is very small, okay? The error boundary is only 5 days. So that means the best scanning. Normally people run for all that scan. Hey, what is the date now? What is, you see, look at 28 weeks. When the pregnancy is above 28 weeks, the error boundary is 3 weeks. That means that you can actually be wrong within 3 weeks. Better you use the CRL. Dating scans are done as early as possible, and mothers should be able to produce that. Or you should be able to, when you start practicing, you should be able to have that done. What is the risk of using catheter? Of course, you're inserting catheter in someone. It may actually cause a little bit of injury, a little bit of infection, risk of infection. It can also, some people think it can cause malpresentation, but that is not very common. There may be some small bruising or necrosis of the heel face or something like that when it gets in touch with the catheter. But that is it's a very rare thing that never occur. But been practicing, I've not seen one having that. Now, how do you induce with Oxytocin? This is Uganda clinical guideline again. Oxytocin, you normally give it 2.5 in 500 mils of normal saline. And then you start at 10 drops per minute. This is something that you need to remember. Whatever it takes, you need to remember this, because this is something that you will be able to do when you're doing your practice. And then you do this every 30 minutes until you get a good contraction. What are good contractions? Good contractions is when you have 3 to 5 contractions in 10 minutes. And each of these contractions lasting at least 40 seconds. That's when you actually stop. So that means if you put 2.5 international unit in 500 minutes of normal saline, you start at 10 drops per minute. After 30 minutes, you check for the contraction. If the contraction is not good, you increase it by 10 drops per minute. That would be 20 drops per minute. You again check after 30 minutes. After 30 minutes, if the contraction is not enough, not good enough, you continue doing that until you reach a maximum of 60 drops per minute. If you reach 60 drops per minute and there's no good contraction, we call that failed induction. So that's the definition of failed induction. Of course, you need to be careful with uterine hyperstimulation syndrome. Sometimes when you give that, it will actually cause severe contraction, especially when you get 4 contractions in 10 minutes, and each of the contractions lasting more than 60 seconds. It should worry you. That's already causing, it might cause fetal distress, it might cause uterine rupture. Of course, the antidote here is you can give salbutamol, which is not a good thing because it can cause a lot of maternal distress. You know, salbutamol, when it's given, it can cause you a lot of palpitation, and that you need to be careful. Of course, IV salbutamol, I've not seen in the market, but it's one of the antidote for uterine hyperstimulation syndrome. Of course, during induction, you need to monitor the fetal heart closely. You really need to monitor the fetal heart, and that's very important. Do not use higher doses of oxytocin, especially in multigravida, previous cesarean section. You're going to cause a rupture. And when you are doing induction, never leave that woman alone. There should be someone there. For a prime gravida, because that uterus is not quite used to a contraction, you can actually give a higher dose of 10 international units in 500 mils of normal saline, and then you keep doing what we discussed earlier on. That can actually do. Failing induction can be because of first stage arrest, and especially first stage arrest maybe when the dilatation is more than 10 centimeter with rupture of membranes. It can also be because of second stage arrest. Second stage arrest can be because of no descent or no rotation after 4 hours in nulliparous with epidural, or 3 hours in nulliparous without epidural. This is actually what they call delayed second stage. So second stage arrest is a delayed second stage. Membrane sweep, or stripping of the membrane. You realize in the initial, the other slide we're calling it stripping the membrane. It's actually called membrane sweep. Normally, membrane sweep should be offered routinely to all pregnant women expected to have a spontaneous vaginal birth by 39 and 40 weeks, between 39 and 40 weeks. This will increase the rates of spontaneous labor onset. And it's something that is very easy to do, although it can cause some little bit discomfort to the mother. I think it's something that benefits them and increases the risk, the chance that a woman goes into labor. Again, these are the cautions when you're considering a woman for induction. One is that do not start oxytocin within 8 hours from using misoprostol, and this is the common mistake that people do. You actually see these people doing. After giving misoprostol, they just connect oxytocin. This is very wrong, and that's actually a caution that's well written in Uganda clinical guideline. You need to carefully control this infusion of oxytocin. Do not give it rapidly. You need to monitor the fetal heart and then the uterine contraction. There should be avenue of you doing an emergency cesarean section. Very important. You cannot start induction in a place where you think you cannot do cesarean section. So one backup plan for induction is cesarean section. You can't start in your clinic. You can't start in a health center 3 because you cannot do cesarean section. Health center 4, don't do it if you don't have an avenue where you can do cesarean section. Of course, complication, failed induction account for 15%. This we talked about it already. Uterine hyperstimulation account for up to 5%. Cord prolapse, because sometimes as part of the induction, people do rupture of membranes, and this can cause cord prolapse. Infection, multiple VEs, catheter, we talked about that. Pain. Of course, induction is more painful than normal labor. this is something that we need to discuss with these mothers. They say no. Induction is very painful. You are more likely to get into interventional birth compared to spontaneous delivery. Like you're more likely going to undergo cesarean section, you're more likely going to undergo instrumental deliveries with induction. And then uterine rupture can also occur, especially if you don't attend to it. We already talked about this. Induction should only be performed only where there is a clear medical indication. You cannot do induction for income-generating activity. A mother can tell you, I want this baby out by this date. I mean, there should be a clear backup why you want to do induction. And this should be performed in a place where you can actually monitor the uterine contraction, and then you also monitor for fetal distress. Very important. So you cannot just do it where you don't even have a fetoscope. You don't even have time for that. There should be facilities to assess the well-being of the mother as well. If you have given oxytocin, misoprostol, or any other prostaglandins, like we have glandin G in our market, you should not leave the mother unattended. Sometimes many people qualify failed introduction into cesarean section, but sometimes when you give them time, it actually works out. So failed induction does not necessarily indicate cesarean section. You need to assess and see. Maybe your Bishop score was not okay. Maybe there was another problem that can be sorted out, and then you can actually do the induction all together. But probably if you want to do another induction, give time, maybe between 24 to 48 hours, then you start it over again. Cesarean section, I said this in the previous slide. If you cannot offer cesarean section, don't waste time doing induction in your facilities. Thank you. We'll discuss any other questions when we meet. Thank you.